I didn't understand what is the international perspective, but I understand to share my experience past 30 years about the scholarly surgery. So I show you my experience. Everybody knows that the concept of skull-based bypass is to make the space to manipulate the target lesion by removing the skull-based bone. Of course, we need to preserve everything, normal structures, zero vascular structures. This is a very important point. Firstly, I show you my transcavenous approach to a distal basilar aneurysm. This is the left side cerebral aneurysm. In the left, the contemporary craniotomy. This is a standard contemporary craniotomy, and this transfusion approach as an anterior temporal approach. Simultaneously, middle cerebral aneurysm was clipped after the clipping of the basilar aneurysm. Anyway, this is the aneurysm just behind, just inferior to the tentorium. And as I expected, the oculomotor nerve is stretched above superiorly by the aneurysm and adherent to the aneurysm. And the most important thing is that aneurysm was compressed the cerebral peduncle, and this is the finding oculomotor nerve, very strongly attached. In order to grip the aneurysm, to relax the oculomotor nerve because it is too much stretching. So we switch to epidural antetemporal approach by feeding up the dura propria from the lateral cavernous sinus wall. And dura is incised along the tentorial edge, and oculomotor foramen is released and to make it mobilized, release the oculomotor nerve. Then compressed cerebral peduncle is detached from the aneurysm, and tiny perforators are confirmed. That perforator just on the neck must be preserved. And I'm confirming the ipsilateral origin of P1, as well as the tiny perforator attached on the dome neck. And now the contralateral P1 and the basilar front could be occluded. Then you can grip the aneurysm. The key in this surgery is the releasing oculomotor nerve. As I compress the oculomotor nerve during manipulation of aneurysm, we can reduce the risk of the post-operative oculomotor nerve growth. Fortunately, the patient recovered well post-operative angiography like this. The next case is a 79-year-old female. Again, this is a right side large superior cerebral aneurysm. The orbital skeletonization is a very good procedure to make the space as a skull-based approach. And again, this is a transcubian approach. And in this case, the arthroscopic change of internal carotid basal trunk is so strongly expected. So I'm doing the epidural dissection. And in this case, because of the very narrow retrocaudal space due to the very strong arthroscopic change of internal carotid, so I am dissecting the fourth nerve in order to extend the Parkinson triangle between the fossa and the V1 of trigeminal nerve, as well as the oculomotor nerve foramen and the cavernous segment of oculomotor nerve is dissected. And I made the oculomotor nerve mobilized. And this is a dissected trochlear nerve. And now the Parkinson triangle could be extended like this. And I'm confirming how can I have the basal trunk. In order to make the space to put the temporal plate on the basal trunk, I'm incising the Parkinson triangle and confirm the Greenwood ligament. And here, I could secure the space to put the basal trunk just lateral to a foresman. And I expected a strong adherence of the aneurysm to the proximal oculomotor nerve like this. Usually a supracerebral, the large aneurysm always stretch or adherent to the oculomotor nerve. In this case, I have as well as in the previous case. So, but with this appropriate approach, we can definitely perform the important normal structures just behind the aneurysm. All the important operators could be confirmed. The important thing to perform such a complex surgery, we need to understand the anatomy, especially cavernous sinus. This is a very important landmark of cavernous sinus. Everybody knows, but in a cadaver dissection, we can learn how to dissect how the cranial nerves are located in the cavernous sinus wall. Sometimes we need the combined petrosal approach, the anterior petrosectomy and the posterior petrosectomy. We have to do it simultaneously in order to perform the safe bypass. This is the previously coiled left side vertebral aneurysm. But the other side has the growing up of the push-form aneurysm. So in this case, I'm doing the combined petrosal. Now I am skeletonizing the semicircular canals in order to secure the space just posterior, just suited to the diabetes. And by this procedure, we can reduce the temporal retraction and secure the space to perform the radial artery P2 bypass. Without a mastodectomy like this, only subtemporal approach, the temporal retraction that become stronger to avoid the temporal contusion something. It's a very good solution to safely perform the P2 bypass. And this is the B3 radial artery bypass at the end-to-side anastomosis. Then you can occlude the vertebral artery distal to the B3 bypass. Now you can open the radial artery bypass as a reconstruction of the basal trunk. And finally, the aneurysm is trapped and bypass is made. Lastly, I talk about the lateral suboccipital skull-base anatomy. Especially to do a transcondylar fossa approach, we need to understand this anatomy. This is a very important landmark. This is an actual case, 46-year-old female thrombosed distal aneurysm like this. The aneurysm is compressing medulla oblongata and the cerebrum, preoperative prediction by my young colleagues. Usually we try to draw the illustration like this. After the layer by layer muscular dissection, occipital bone, suboccipital bone is exposed, and posterior condylar hemispheric vein is secured and up. Then we can drill the condylar fossa and skeletonize hypoglossal canal. You can see the blue line of hypoglossal sinus. And before opening dura, we can confirm this anatomy. Then the cranial nerve, lower cranial nerve toward the jugular foramen, and proximal pica to the aneurysm could be confirmed. And this is the thromboid aneurysm, just inferior to the tonsil. The pica distal to the aneurysm could be secured in order to perform the occipital pica bypass. During the layer by layer muscular dissections, occipital artery is harvested like this, and ICG video angiography shows a good patency of occipital pica. Now, we can incise the aneurysm to decompress the brainstem and the cerebrum. After decompressing the aneurysm by the thrombectomy, you can secure the proximal pica and the distal pica, just distal to the aneurysm, just proximal to the aneurysm. And you can confirm the indent and outlet of a pica. And we can safely separate the aneurysm. The inferior halfway of the aneurysm was strongly adherent to the brainstem and the cranial nerve, contralateral cranial nerve. So I released it, I left it, okay. And pica is retenous most to maintain the antebrain flow. And this is the final view. The pica and the reconstructed pica itself to be preserved. This is the last case, 53-year-old female, bilateral vertebral pica and vertebral aneurysm. In this case, if we perform the simple vertebral artery occlusion, in the other side surgery, we have to reconstruct the radial artery. So, in our first operation, in the easier side, I try to reconstruct the vertebral artery after the resection, flap resection of the aneurysm. This is the aneurysm left side, vertebral artery. You can see the contralateral vertebral artery is just below it. And in the depth, you can see the vertebral union. This is a radial artery harvested by my colleague. Now, the distal intracranial V4 vertebral artery and radial artery on the small side, end to end. And the proximal end of radial artery is exposed to a proximal intracranial vertebral artery. Here it is. Then you can open it. And you can reconstruct the vertebral artery, left side vertebral. That is the vertebral union. The other side is the vertebral artery. And this is the post-operative view, and the diffusion image shows nothing, visionary protocol. So the other side, the later treated. So in conclusion, we need a bloodless cavernous dissection to confirm the structures, anatomies, and you can extend the inferior operative space in a retrocarotid front. Releasing oculomotor foramen is very useful to reduce the oculomotor pose. And combined Petros approach, this reduces the temporal retraction when we perform the P2 bypass. to show the actual layer by layer suboccipital muscular dissection, but it makes suboccipital operative field shallow, especially to perform the occipital like something. You can use a shorter instruments to perform the finding like this. And condylar force drawing, you can skeletonize hypoglossal sinus, hypoglossal canal. With this approach, we can have the extreme lateral, very wide operative field in a paralateral suboccipital approach. That's all. Thank you very much.